Hello, everybody. Our case was about a 46-year-old woman in Botswana who presented with postcoital bleeding. Here's some general information about the patient. Both her and her husband are HIV positive and receiving ART, which is a combination of antiretroviral medications to treat HIV and HBV. She is gravida 7, para 5, meaning she has had 7 pregnancies and 5 births, and she has no allergies or family history of cancer. At the time of the presentation, there was no self-reported dyspareunia or postcoital bleeding. Her blood count, creatinine level, and liver function were normal, and she was still taking ART. So I'm going to go through her health history now. Our patient received the HIV diagnosis 6 years prior to the presentation through government testing recommended after she complained of pelvic pain and weight loss. 4 years prior to the presentation, she received a blood test showing her white cell count of 3,400 cells per cubic millimeter, blood level creatinine at 0.41 milligrams per deciliter, and a CD4 plus T cell count of 193 cells per cubic millimeter. All of these test results are significantly below the reference range, which caused her to be eligible to be on ART, and she started taking tenofovir, which treats HBV, emtricitabine, which treats HIV, and efavirenz, which also treats HIV. And there's a summary slide that tracks these blood results from 4 years prior up until the time of presentation that Ines will go over. She also received a gynecological exam at this time, as she was complaining of vaginal discharge, frequent urination, and dysuria, which is pain or discomfort when urinating. The initial results of the exam just showed general abnormalities, and she was prescribed a 10-day course of amoxicillin, which is a penicillin-type drug. The Pap test went on for pathological examination, and it showed low-grade squamous intraepithelial lesions, but the patient never received this result. The figure on the left shows the different levels of lesions from normal to cervical cancer. In her first Pap test, it showed low-grade squamous intraepithelial lesions, which is LSIL, and in the second Pap test, which I'll go over in the next slide, it showed high-grade squamous intraepithelial lesions, which are HSIL. There's a really large jump in results here from 4 years to 13 months prior. This is due to the fact that the patient sought treatment from traditional healers and postponed reporting to medical caregivers. She had no Pap tests, and she believed this would help her symptoms, but they stayed the same. And she returned 13 months before presentation, as she was experiencing vaginal pruritus, which is just itchy skin.
That's at the same magnification?
Yes. These two?
Yeah.
No, they're not. E is a more zoomed in area of the area in B. So she received a Pap test and speculum exam at this appointment. The speculum exam showed white patches on the cervix, and a Pap test was performed and now showed high-grade squamous intraepithelial lesions. A colposcopic exam with biopsy was scheduled, but the next available was not for 14 months, which is a very long time from this Pap test. The images on the left show a biopsy of the second Pap test, and the affected cells can be seen forming lesions. So in B, the higher definition red areas, and then it's kind of a zoomed in picture in E of the same area where you can see the lesions beginning to form, especially in the upper right and lower left. The 1 month prior to presentation, the patient received another Pap test and abdomen examination. Her abdomen was soft and normal, but the pelvic exam showed ulcers at the introitus and a malodorous fungating lesion 6 centimeters by 2 centimeters on the right lateral vaginal wall. It extended from the fornix to the introitus. There was minimal bleeding on contact, and the cervix was nodular. The image here shows the results of an HPV test that was taken at this time, and we can see the affected cell area where rapid and abnormal differentiation is especially clear in C. And C is also a zoomed in picture of what the arrow is pointing to in B.
So moving on to the differential diagnosis, at the time of the presentation, the HIV positive woman has been on treatment for HIV for 4 years, so with antiretroviral therapy. But she also had 10 months of recurrent postcoital bleeding, intermittent urinary frequency, dysuria, pelvic pain, and vaginal discharge. So she showed great virologic suppression, so we can see that in table 1 with the HIV RNA, with the reference range of less than 400. So by 1 month prior to the presentation, her value was falling into the reference range, which kind of showed the progress as she progressed with the ART treatment. We can also look at the CD4 plus T cell count, which was represented in cells per millimeters cubed. The reference range is 467 to 1,603. So we can see 4 years before the presentation, her count was really low. And as she progressed with the ART treatment, there was an overall increase to 483 1 month prior to presentation, and that count falling to the reference range. However, it is important to note that the reference ranges used at the Botswana clinic are for adults that are not pregnant and that do not have medical conditions, and that could have affected the accuracy of the results for this woman. So the combination of inflammation of the vagina, melligerous fungating lesions on the vaginal wall, as well as the nodular cervix, was highly suggestive of cancer, which led the doctors to do prompted biopsies of specimen of both the cervix and vagina mass. So the first diagnosis was cancer of the cervix, because it is the most common cancer for women in sub-Saharan African country, and especially in those with HIV infection. Also, approximately 11% of patients that are diagnosed with cervical cancer show postcoital bleeding following the diagnosis. And this patient's history of Pap test, which showed both low-grade and high-grade squamous intraepithelial lesions, followed by the recurrent postcoital bleeding, was highly suggestive of cervic cancer. So in table 2, we have the causes of postcoital bleeding, and we can see that the majority are from lower genital tract epithelial lesions, but it also could occur from endometrium lesions. And although the majorities of the conditions are benign, the consideration of cancer was suggested because of this patient's age group. Another possible diagnosis was cancer of vagina. Although this patient's lesions increased rapidly, it is possible that some lesions were missed during earlier examination. And this possibility, together with the significant arising of lesions in a very small time frame, makes the rare diagnosis of primary vaginal cancer very likely. It is also significant to say that there are no direct guidelines for screening for vaginal intraepithelial neoplasia, and detection usually arises from involuntary findings. Lastly, genital HPV infection, which is associated with multiple risk factors that we can see in table 3, especially multiparity and immunosuppression, which were both very significant for this patient's case. HIV and HPV are also interrelated sexually transmitted diseases, and they share similar risk factors as well as facilitating each other's acquisition, which most likely happened in this patient. And it's also significant to add that chronic infection of high-risk type of HPV can lead to cancer development. So leading on to the pathological discussions, the patient's second Pap test showed clusters of small cells that we saw during Eleanor's presentation. There was a high nucleus to cytoplasm ratio. We could also see nuclear hyperchromasia and variations in nuclear size and shape, which was consistent with high-grade squamous intraepithelial lesions. On the receipt of the biopsy specimens, they also performed nucleic acid testing, in situ hybridization assay, and immunohistochemical assays. And based off the results, they were positive for high-risk HPV. And also, although it wasn't the most common HPV, high-risk HPV, it was still very relevant. The in situ hybridization also showed a strong and diffuse staining patterns for P16 protein, which is a kind of protein that is very predictive of cellular transformation into precancer or cancer cells. The biopsies of the cervix also showed papillary connective tissue stroma covered by thickened epithelium, which also was consistent with condyloma acuminata, which is basically genital warts associated with the high-grade squamous enteroepithelial lesions. And the examinations of sections of the vaginal mass showed two different findings that align with invasive squamous cell carcinoma. So they found the presence of, in the lamina propria, of irregular cords, and also found nests of keratinizing squamous cell carcinoma. So all these molecular and immunohistochemical findings supported the final diagnosis of HPV-related vaginal cancer.
Okay, so knowing this diagnosis, the goals of the treatment were to maximize the permanent eradication of the cancer while minimizing the effects on the normal cells. So the patient receives two types of treatment, the first being chemoradiation and chemotherapy, which was aided with the chemotherapeutic cisplatin, and the chemoradiation targeted the entire lymphatic drainage system of the proximal and distal vagina. And along with that, intravaginal brachytherapy was given, which targeted the initial area of the tumor. And for the antiretroviral treatment, it did not change with the chemoradiation and brachytherapy. And the ART tenofovir can cause renal function to degrade as well as cisplatin. So the renal function of the patient was closely monitored, and she was given additional hydration during the process as well to make sure that the renal function did not change.
How old was she?
48.
Yeah. And after a year of the treatment, the patient saw complete disappearance of the primary cancer and could resume normal sexual activity. So the underlying problem of this patient was the fact that she lives in a low-income setting, and there are a lot of barriers to her treatment. So the first just being the limited oncology services in Botswana, and the fact that MGH had to do a lot of the treatment over the telephone and had to do most of their assistance online, and that drew the process out for a very long time when she could have gotten the diagnosis a lot sooner. A few other things that could have been changed due to her setting in a low-income setting was the fact that she never received a colposcopic evaluation because it wasn't available for 14 months, and that could have led to her discovering her diagnosis a lot sooner. And as well as the Pap test, she never received the results of her first Pap test, and it took another year to receive the second Pap test. Some of the available treatments that could have been taken instead of the ART, the tenofovir, which would have not had side effects on renal function, were costly and not available in the region. So the patient could not receive those. Luckily, they did not degrade the renal function, but it was definitely costly. It would have been a much more safe treatment. So.
Thank you.